This is the second part of the lecture on the endocrine system, essential hormones. And in this part of the lecture, we are going to learn the pancreatic hormones that regulate blood glucose level and hormones involved into calcium blood level regulation. Let's start from the endocrine function of pancreas. Pancreas is a large exocrine gland that produces pancreatic juice, which contains various digestive enzymes. But among regular secretory SNR cells, there are inclusions of an endocrine tissue, the islets of Langerhans. These pieces of endocrine tissue contain three types of cells. Alpha cells secrete glucagon. Beta cells secrete insulin. And delta cells secrete somatostatin. Two main hormones, insulin and glucagon, are main for regulation of glucose level. As for somatostatin, its effect is to inhibit secretion of both alpha and beta cells, as well as inhibition of gastrointestinal secretion and motility. Also, it can be noted that chemically it is the same somatostatin that decreases growth hormone secretion from pituitary gland, or growth hormone inhibition factor. But pancreatic somatostatin participates only in digestive functions regulation, while hypothalamic somatostatin acts within hypothalamus pituitary system. The main factor that regulates glucagon and insulin secretion is blood glucose level. If blood glucose level starts to decrease, it stimulates secretion of glucagon from alpha cells, and opposite, increase in glucose stimulates insulin secretion. Let's first consider glucagon, as it has a shorter list of effects, and it acts only in the liver, where it activates the 7 transmembrane segment receptors that operate through adenylate cyclase cyclic AMP pathway. Stimulus for secretion of glucose, as it was mentioned already, is a decrease of glucose level. And glucagon produces the opposite effect. Its major action is on blood glucose, and this is increase of glucose level. But it's not the only one effect. Let's list all the effects that develop due to glucagon action. First, it increases glucose level by stimulation of the process of glycogenolysis and also gluconeogenesis. It means that glycogen is split into glucose, and also new glucose is formed from non-carbohydrate sources, which mostly are amino acids. Also, glucagon stimulates breakdown of lipids, lipolysis, and increases the production of ketoacids, which always associated closely with breakdown of lipids. As a result, in blood we have increase of blood glucose level, increase of fatty acids, and in parallel, increase of the level of ketoacids. These are main effects of glucagon. But to understand better action of both glucagon and insulin, we need to consider in general the pathways of formation of glycogen, glycogenesis, and catabolism of glycogen, glycogenolysis. First, for glucagon, it's necessary, this shows the liver cell mainly, it's necessary to split glycogen and finally convert it into blood glucose. And the main effect of glucagon is stimulation of the enzyme phosphorylase. Exactly this enzyme is activated by glucagon by its action through adenylate cyclase cyclic AMP pathway. As a result, protein kinase is activated, which in turn activates phosphorylase in the liver cells. And phosphorylase begins the process of glycogen breakdown, glycogenolysis. Glycogen is converted to glucose 1-phosphate and glucose 6-phosphate, and finally the enzyme phosphatase splits the phosphate group from glucose, and glucose is formed. As glucose becomes high in the liver cells and outside glucose is low, which is stimulating factor for glucagon secretion, glucose easily goes out of liver cells into blood, and thus the glucagon increases level of blood glucose. Also, at the same scheme, we can observe the opposite effects developed due to insulin action. What these effects are? They are more numerous. First, insulin inactivates phosphorylase, so it stops glycogen breakdown. Then, it inactivates phosphatase as well, and it activates a number of enzymes. First to be mentioned is glucokinase. For the liver cells, the enzyme glucokinase converts blood glucose, which enters the cell, into glucose 6-phosphate. And then this glucose cannot leave the cell anymore because it contains this phosphate group. And it makes more glucose molecules enter the cell because glucose concentration is actually absent in the cell, and glucose 6-phosphate is another substance. And it's for the liver cell that it's glucokinase. In other cells where glycogen is formed, this is hexokinase. Insulin activates this enzyme, but also insulin activates the glycogen synthase, which polymerizes the monomeric monosaccharides into polymeric molecule of glycogen. So you see, action of insulin is exactly opposite to the glucagon. Now let's observe all the effects of insulin. It has more effects and more complex, and it acts not only in the liver but also in the main insulin-dependent tissues, adipose tissue and muscles, and some other tissues as well. So insulin, as you remember, operates through tyrosine kinase activating one transmembrane segment receptor. The main effects of insulin are, first, maybe it's better to mention first that it acts on all types of nutritional substances, metabolism, on proteins, fats, and carbohydrates. But of course, the first to be mentioned is effect on carbohydrate metabolism, which involves increase the glucose uptake into the cells. And to facilitate this process, it stimulates insertion of specific glucose transporters into membranes of the insulin-dependent cells, adipose tissue and muscle. This is so-called glucose transporter 4, GLUT4 insertion. We'll talk separately about this. Then it stimulates synthesis of glycogen and simultaneously blocks glycogenolysis, if you remember. And also it inhibits gluconeogenesis. So due to all these three effects, glucose is successfully taken from blood, converted to glycogen, and glucose level in blood decreases, which is the main effect of insulin on carbohydrates. Then for proteins, insulin stimulates uptake of amino acids into cells and formation of proteins. Synthesis of proteins is stimulated by insulin. Actually, in this function, insulin is the synergist of growth hormone, and it was shown that only growth hormone cannot provide such efficient growth without an additional action of insulin. So they operate together to provide protein synthesis and growth of the body. Then, fat synthesis is also stimulated, and simultaneously the breakdown of lipids is suppressed by insulin. And keto acids are formed less due to less lipolysis, and keto acids oxidation is promoted, so their level becomes decreased. And finally, potassium uptake into cells also is stimulated. It's usual when glucose is taken into cell, as well potassium ions are taken into cells, so the level of potassium in blood decreases. First, let's observe what the direction of all the main effects on metabolism of fats, proteins, and carbohydrates. You see, synthesis, and synthesis. So, glycogen is a complex substance formed out of simple substance such as glucose. Protein synthesis is stimulated from simpler amino acids. And fats, triglycerides, are formed out of fatty acids. So, in all cases, we have similar direction of metabolic reactions. From simple substances, we form complex body substances, which is referred to as anabolism. Therefore, insulin is entirely anabolic hormone, which is unusual. Most hormones have combined effects. They may stimulate synthesis of some substances, while the other substances are broken down, so catabolism is observed. And insulin is entirely anabolic. So actually it makes it much easier to memorize that. If you need to remember, all effects are stimulation of synthesis. And if you observe the effects in blood, they all are directed similarly. All changes occur in one direction. Due to these first three effects, glucose is taken into cell, converted to glycogen, while glycogenolysis is inhibited, so blood glucose is decreased. Here, glucose in a square bracket, which means that it is a concentration of glucose. So concentration of blood glucose is decreased. Similarly, concentration of amino acids is decreased because amino acids are taken into cells and converted to proteins. Then fat synthesis requires entry of fatty acids from blood into cells, and level of blood fatty acids also decreases. And then you can predict that keto acids become oxidated. They are less formed and more oxidated. Therefore, keto acids level also decreases. And finally, potassium level also decreases. So all these changes are decreasing of substrates necessary for production of complex substances in the body cells. And also there is a decrease of keto acids and potassium blood level. Now let's observe in more details the glucose transporters, which are inserted into cells' membranes under action of insulin. It refers to insulin-dependent cells, and we mean here the muscle cells, skeletal muscles, and fat tissue cell. Look, in the absence of insulin, the cells have glucose transporter number 4, GLUT4, but it's not present in their membranes. So there is no transport of glucose from outside to cells because glucose transporters are internalized within the vesicles located inside the cell. And when insulin appears, binds to its 1-TMS receptors, it results in events inside the cell that bring the vesicles into the membrane, and transporters, GLUT4, become inserted into membrane. And now you can see that transporters start to move glucose from blood, from extracellular fluid into cells. So these are GLUT4 inserted into membrane that allow entry of glucose to the insulin-dependent cells. Actually, that's why they're called insulin-dependent, because their glucose supply occurs only when insulin is present. And now, this is a very important slide that explains how we switch from glucose to fat metabolism in many cells due to changes of glucose level and due to insulin-glucagon ratio. First, let's consider the moment just soon after meal when glucose level in blood becomes high. And this high level of glucose, of course, stimulates secretion of insulin and inhibits glucagon secretion. In this situation, glucose is available for all the cells, and insulin-dependent tissues can get glucose from blood. Let's observe first what happens in the liver. The middle cell is the liver cell, and here there is a transporter which is different, not insulin-dependent, GLUT2 transporter that allows glucose to move through membrane. And this movement goes down the gradient, down the concentration gradient of glucose. But as you remember, insulin is secreted when glucose level in blood is high. So glucose level in blood is high and glucose easily enters the cell. And gradient is constantly kept, and because glucose is immediately converted to glucose-6-phosphate by glucokinase, if you remember, which contributes to absence of glucose molecules inside the cell. And glucose continuously comes into cells, where the next stages go, and glucose-6-phosphate gradually is converted to glycogen. And part of glucose can be converted, especially excessive glucose, converted to fats. to triglycerols. Then, for insulin-dependent tissue, now exactly into skeletal muscle cells and adipose tissue cells, insulin contributes to insertion of GLUT4. And this GLUT4 is used for formation of glycogen in the muscle cells and formation of entry of glucose into fat cells and formation of triglycerols. So in this situation, glucose is available for all the cells. And as for the cells of brain shown above, brain cells have specific transporter not dependent on insulin, GLUT3, which allows brain to get glucose always, regardless of presence of or absence of insulin. Glucose can easily enter the brain cells, just it's necessary to have enough glucose in blood. Now, let's imagine that certain time has passed in this moment and insulin successfully decreased glucose level. And now glucose starts to decline, so that glucagon is secreted. And when glucagon is high and insulin is low, glucose again is released by liver cells, but now this glucose is only for brain. Let's observe in details. Here, liver cells, through the same GLUT2 transporter, releases glucose outside into blood, because glucagon contributes to glycogen breakdown into glucose 6-phosphate by phosphorylase, and then glucose is converted in glucose 6-phosphate by phosphatase is converted to glucose simply, and therefore glucose is accumulated in the liver cells, and while glucose is low outside in blood, glucose easily goes transported by GLUT2 transporter outside of the liver cell. So due to this, liver produces its function as buffer for glucose level. When glucose is high, excessive glucose is taken by liver cell and stored as glycogen. When glucose level decreases, liver starts to release this glucose due to glycogenolysis. It releases into blood, and therefore it keeps level in blood for glucose at a rather constant level within certain limits, within certain range. Then you can see that now insulin-dependent tissue without insulin, they don't have GLUT4 transporters, and glucose cannot be taken into these cells. Therefore, they have to switch to metabolism of stored glycogen for muscle cells, but note that muscle cells use this glycogen only for themselves. They do not release it into blood back. And also, the adipose tissue cells simply use triacylglycerols to split into free fatty acids and glycerol, and then it can be taken. And also notice that ketone bodies are produced, therefore, due to the breakdown of lipids. And these ketone bodies become higher level in blood. And brain, as usual, can get glucose due to GLUT3 transporter. And so brain can have glucose regardless of presence or absence of insulin. Let's move to the insulin pathological physiology, which is very widespread type of pathology, diabetes mellitus, or mellitus, sugar diabetes, so-called. And if you remember normal effects of insulin, you easily can deduce the effects of insulin insufficiency or absence of its effect, which symptoms can appear, which changes. First, if normal function of insulin is to decrease glucose, and insulin deficiency or lack of its effect results in excess of blood glucose level, hyperglycemia. And this hyperglycemia results in loss of glucose, excessive glucose with urine, glucosuria. When normal glucose in fasting state in blood is from 3.3 up to 5.5 millimole per liter. When it increases up twice maybe, only then it starts to be released, to be excreted through kidney. And threshold of excretion is about 10 millimole per liter. So when glucose blood level reaches this level and more, or when it becomes higher, glucose starts to be present in the urine. And due to this, as it's a osmotically active substance, it takes along certain amount of fluid and certain amount of water. So there is loss of fluid greater than normal, and diuresis becomes higher. And in severe cases, it can be 6 to 9 liters daily, which is, as compared to normal, usually does not exceed 2 liters or so. So it's a loss of water. So this is decrease of the extracellular fluid volume, and it develops tendency to hypotension in these people. Then protein catabolism. Insulin normally contributes to the synthesis of proteins, and now opposite reaction occurs, protein catabolism. And many consequences can be deduced from this: muscle weakness and many different problems for the body. Then lipolysis. Then ketoacids formation, and this is also very, in severe cases, can be serious problem because it produces severe metabolic acidosis, because ketoacids are the acetoacetic acid and beta-oxybutyric acid. Both are acids, and so acidosis follows. And lack of insulin and great lipolysis level produces accumulation of ketoacids, and therefore the oxidation does not occur, so they can become accumulated. And in severe cases, even acetone can be formed, and so the expired air of patients in such state can contain acetone, which can be smelled by the doctors and by surrounding people. And hyperkalemia also is characteristic. So, but not fully this picture develops in every patient with diabetes mellitus, because diabetes exists in two types. And type 1, insulin dependent, usually develops early and before 20 years, and it's exactly because of insulin secretion decreased due to destruction of the beta cells of Langerhans islets. So this type is less widespread. It makes from 5 to 10% of all patients with diabetes. And much more widespread is a type 2, non-insulin dependent diabetes. This type of diabetes develops slowly, gradually, and usually appears after 40 or mostly after 50 years. And it's highly associated with obesity. One of main risk factors for type 2 non-insulin dependent diabetes mellitus is obesity. And gradually the disturbance of blood glucose regulation develops, and insulin is secreted, but its receptors become less sensitive progressively. And due to absence or lack of effect, gradually insulin secretion even becomes for compensation higher and higher. But nevertheless, it does not give the full effect. And so it appears as deficiency of effect of insulin. So this is much more widespread type. As you can see, it's 90 to 95% of all diabetes cases. And what's the greatest danger of high glucose? When glucose level is high for long time, it gradually starts to destroy vascular walls, to change the property of vascular walls. So many vascular diseases develop, and heart diseases. And it contributes greatly to atherosclerosis. It contributes to damage of the eye retina and many other structures and tissues of the body. But you're going to study this mostly in pathological physiology course. And before we shift to the other hormones, I need to remind you the action of many hormones that are contra-insular. We have in our body only one hormone that decreases blood glucose, only insulin. But there is a number of hormones that increase blood glucose level. Of course, first to be mentioned is an antagonistic hormone for insulin, is a glucagon. But even in a previous lecture part, you could remember that some other hormones produce increase of glucose level. And among them, adrenaline exists, and glucagon and adrenaline both have similar effects because adrenaline stimulates this through the same adenylyl cyclase cyclic AMP pathway, stimulates phosphorylase, the same enzyme that is activated by glucagon. And so adrenaline provides blood glucose level elevation necessary for higher level of body activity when sympathetic system is activated. But in previous lecture it was shown that cortisol, glucocorticoid, that's why it's called glucocorticoid, because it stimulates production of more glucose, but here it's by gluconeogenesis. Then thyroid hormones were mentioned to make glucose level higher. And additionally, growth hormone also is able to do it, and even some tropic hormones of anterior pituitary, such as adrenocorticotropic hormone and TSH, thyroid stimulating hormone, to make sure that they have slightly different mechanisms. At least glucagon, as you remember, stimulates glycogenolysis and also gluconeogenesis to a small extent. Adrenaline predominantly stimulates glycogenolysis. Mostly hormones do like this. But cortisol is the exclusion. It doesn't touch glycogen, that stores, and stores remain for other cases. And glucose is increased just because of formation of new glucose from amino acids, gluconeogenesis. Thyroid hormones, similar to glucagon, stimulate glycogenolysis and, to a certain extent, gluconeogenesis. And the rest hormones mostly have glycogenolysis activation. So we see how many hormones are able to increase blood glucose. And it's easy to understand because in many situations our energy requirements are increased and correspondingly our requirement in glucose, one of the best economical sources of energy, because glucose under oxidation produces great amount of energy and simultaneously it takes less oxygen as compared to fats, which are highly have high amount of energy in kilocalories, but they require great amount of oxygen as well. So with this we finish consideration of glucose blood level regulating hormones and switch to blood calcium regulating hormones. And first let's observe which factors exist for calcium blood level regulation and generally calcium in the whole extracellular fluid, and why it is so important, why so many hormones are involved into blood calcium regulation. Calcium of the extracellular fluid has constant exchange with the intracellular calcium. But calcium, as a charged particle ion, cannot easily move through the cell membranes, and the channels are necessary. And some cells have these channels and they can become open under different factors, and exchange of calcium occurs. But main factors that determine level of calcium in the extracellular fluid are three processes. First, how much calcium enters the body, and here it depends on absorption from intestine. Absorption, of course, can occur only in case of presence of calcium in food. Calcium intake should be a certain level, otherwise there will be no absorption. But even in the presence of calcium, we cannot make sure that an absorption occurs, because absorption usually takes about, normally, under normal conditions, about 35% of ingested calcium, 35%. And to provide this normal absorption, normal amount absorbed, calcium intake should make about 1 gram per day for usual adults. You see, 1,000 of milligram, or simply 1 gram daily. Of course, for some groups of people, like pregnant or lactating women, this requirement is even greater, and for growing children. But for adults, it's about 1 gram. And out of this 1 gram, we absorb about, according to percentage, 350 milligram per day. But nevertheless, through feces, we lose about, in this case of intake, about 900 milligram daily. How it can be, you can ask. And this is because calcium is not only taken from intestine, not only absorbed, but calcium present in many digestive juices which are released into the lumen of intestine. And so with this secretion, about 250 milligrams are lost daily. Therefore, final net absorption makes only 100 of milligram, and the 900 are lost. So this is intake of calcium daily. To keep balance, we should lose no more than these 100, therefore, from the body. Loss of calcium from the extracellular fluid from the body occurs mostly through kidney. Calcium is easily filtered, at least the calcium is in its ionic form, which is free in plasma. It's released easily it passes through glomerular filter easily, but then it should be reabsorbed. So filtration and reabsorption. Actually, filtration goes all calcium that is present easily can go out from through kidney filter. And reabsorption is the factor process which is regulated in order to keep calcium level in blood constant. And normally, when reabsorption occurs regulated well, urine excretion makes the same 100 milligram per day. So it makes the balance of calcium in the body. But the third factor, we have great storage of calcium in our bone system. And actually total amount of calcium is estimated as 1 kilogram. And from this calcium there is portion of exchangeable calcium that can be taken out of bone without even any harm to the bone tissue, to bones themselves. And as bone constantly is under processes of in the process of remodeling, so we can produce deposition of calcium into bone, and we can take some calcium from bone, which is named the resorption process. Please don't mix the resorption and reabsorption. Reabsorption as something we take back, reabsorb. From the intestine, it's simply absorption. From kidney, after filtration, we take it back, so it's reabsorption. And from bone, this is different. Resorption means loss of calcium from the bone due to process of destruction of the bone tissue. And from histology, you may remember that there are osteoblasts that form bone tissue constantly, while osteoclasts constantly produce the resorption processes, which results in release of calcium from bone into extracellular fluid. And normally these processes are balanced, but it's constant process of bone remodeling. And actually, to make a normal balance, deposition and resorption should be equal. And exactly, usually it's about half of a gram daily deposited into bone, and simultaneously half of a gram daily is taken out of bone. But when calcium blood and calcium extracellular fluid level changes, temporarily from bone we can take more calcium or to deposit into bone more calcium, so that to keep calcium of extracellular fluid constant. And why it's so important to keep calcium level? Calcium level in blood measured in millimole per liter usually balances little bit around 2.5 millimole per liter, with variability no more than 0.25 plus minus millimole per liter. It's narrow limits for calcium regulation exist. And all the regulation makes sure to keep calcium in extracellular fluid in blood constant. So again, why it's so much important? It's because calcium blood level greatly influences the excitability of the central nervous system. Membranes of neurons become more or less excitable depending on calcium blood level. And therefore, to keep normal excitability, we need to keep constancy in calcium. Of course, it's not the only one factor. Actually, calcium is important for contraction of the smooth muscles and heart, because these muscle cells have calcium channels in the external membrane. And when these channels are open, calcium enters down the concentration gradient. And concentration gradient can be changed when extracellular calcium level changes. Therefore, calcium can enter more or less, and it changes the contractions of these muscles. But as for skeletal muscles, they are influenced by calcium only through central nervous system, through neurons, because these cells do not use calcium from outside. They do not have even, skeletal muscle cells do not have even channels in their outer membrane for calcium. They use the calcium from their reticulum, sarcoplasmic reticulum. But when neurons become overexcited, they stimulate excessively muscles. Or when neurons become suppressed, they stimulate muscles very little and muscle weakness develops. Therefore, calcium is important for central nervous system and for all types of muscles finally. And here you need to remember that decreased calcium exactly stimulates excitability of the neurons. Neurons' membranes become more excitable in case of calcium deficiency. And this excessive excitability can lead even to tetany. Tetany, these are severe muscle convulsions, when muscle start to contract even without normal stimulation, and finally they can be contracted and stay in this contracted state. So tetany is very severe problem of hypocalcemia. Opposite, hypercalcemia, results in decreased central nervous system excitability. Central nervous system is depressed, reflexes become weak, sluggish, and generally muscle cannot operate normally. So you see that normally blood calcium level is kept very much constantly because we have few hormones that regulate this calcium level. And number one, this is parathyroid hormone. But also in this process of regulation, vitamin D3 participates and calcitonin. Let's start from the most important, which is parathyroid hormone. This hormone is produced by parathyroid glands, and there are 4 of them located on the posterior side of thyroid gland. They are very little, just a few millimeters in their size, but it's enough to produce parathyroid hormones. And this hormone, which is secreted by chief cells of the parathyroid gland, is main hormone that participates in regulation of calcium, and its action is to increase blood calcium level. And so all the processes it can regulate are directed in such a way that calcium level should become higher. So in bone, it contributes to bone resorption. Calcium should be released from bone into extracellular fluid, into blood. In kidney, it stimulates the processes of calcium reabsorption. Also, it stimulates loss of phosphate. P here stands for phosphate. Then, in intestine, not directly but through stimulation of formation of vitamin D3, it increases calcium absorption. So here it's supported by vitamin D3, but parathyroid hormone is also necessary. Then let's observe effects of its synergist, vitamin D3, which is formed in kidney finally. We'll observe the full pathway of formation of this vitamin. Its action the same, increase of calcium level in blood, and mostly it's achieved through intestinal absorption stimulation. And you see here not only calcium is absorbed but also the phosphate. In bone, here its effects not easily understood, because in high doses this vitamin may stimulate resorption, but in smaller doses it mostly contributes to formation of the bone, calcification, like deposition of calcium into bone. Here it's not always the same effect. And in kidney it stimulates reabsorption. But among these effects, number one is in intestine and second effect in bone. In kidney, effect is rather weak, and mostly reabsorption occurs by parathyroid hormone. But only you can notice that effects for calcium are similar for parathyroid hormone and vitamin D3, but phosphate is reabsorbed due to action of vitamin D3, while reabsorption of phosphate is decreased by parathyroid hormones. Otherwise, they are synergist. And the opposite hormone, calcitonin, which is secreted by the thyroid gland, but not follicular cells which produce T3 and T4, but perifollicular cells. And its action is opposite, to decrease calcium blood level. And mostly it's achieved through bone, and it inhibits resorption so that calcium deposition occurs and calcium is decreased. So now let's observe in more details the formation of vitamin D3, which is important. Vitamin D3 first is formed in the skin under sunlight and to be more exact, ultraviolet rays. They contribute to formation of first vitamin D3, which is not much active initially because it requires some modifications, and this modification is hydroxylation. The first hydroxylation occurs in the liver, and in 25th position of the molecule, the OH group is added. So this hydroxylated vitamin D3 also is not highly active as compared to final active one. And its 25-hydroxy vitamin D3 should be converted to active form, which occurs, this last reaction occurs in kidney. In 25th position, OH group is already present, and one more is added in the first position, and then it becomes highly active 1.25 dihydroxy vitamin D3. It's considered to be a hormone, and it also has the name calcitriol, but it's the same, active vitamin D3. And this process of conversion of 25 hydroxy vitamin into 1.25 dihydroxy vitamin that occurs in kidney is stimulated by parathyroid hormone. Therefore, parathyroid hormone is necessary to produce more calcitriol, more vitamin. And then its target organs are number one, intestine, also bone and kidneys. And the primary action is higher intestinal absorption of calcium from gastrointestinal tract, from intestines, as well as phosphate. Actually, for intestinal absorption, vitamin D3 stimulates nuclear receptors, as it's a lipid-soluble vitamin, so it's lipid-soluble hormone that should enter the cell simply by diffusion and then bind to intracellular receptors. In particular, they are nuclear receptors. And it stimulates in nucleus formation of specific calcium-binding protein, which enables to transport calcium from lumen of intestine into cells, and then calcium is absorbed due to this. Hormonal regulation of calcium blood level. Now let's start from the change of calcium, and first let's see the factors that can be regulated. This is absorption from intestine. Calcium is taken, but absorption can be from 0 of ingested calcium to maximally 35%. Then kidney. Here we regulate reabsorption, and less reabsorption results in high excretion and so on. And finally, also we can regulate amount of calcium through storage of calcium in kidney, or in bone, in bone, where due to bone remodeling we can have processes of resorption and formation. Balance between these processes can be shifted temporarily to produce correction of calcium blood level. Let's start from case when calcium blood level decreases. This decrease in calcium is the stimulus for secretion of parathyroid hormone and formation of vitamin D3. And resulting effect should be opposite to decrease calcium. We should increase calcium back to normal. And how it occurs now? Parathyroid hormone starts to stimulate bone resorption. Actually, parathyroid hormone can do it even faster than produce resorption of bone, because, as I mentioned before, there is exchangeable calcium in the bone tissue, which can be quickly released into blood, and it doesn't require even activation of osteoclast function, because it takes longer time. So first faster effect occurs within hours. This is the release of calcium from bone simply from pool of exchangeable calcium. But then, with longer effect, parathyroid hormone contributes to activation of osteoclasts. In particular, the receptors for parathyroid hormone in bone tissue are located on membrane of the osteoblasts. But when parathyroid hormone binds to this receptor, it changes the function of osteoblast, and they stop to release one substance and produce some other substances that in turn activate osteoclasts. And osteoclasts start to produce their resorption, which is a degradation of bone tissue and release of calcium into blood. So in a faster type of effect and longer type, all result in higher calcium blood level. Then in kidney, higher reabsorption is stimulated mainly by parathyroid hormone, but also vitamin D3 contributes. So increased reabsorption. So less calcium is excreted from kidney. And finally, calcium intake is accompanied by greater absorption of calcium. Vitamin D3 here is stimulating factor, which produces it again by formation of calcium binding protein in the intestinal cell membranes. So absorption is increased, but of course it's necessary to remember that if calcium is not present in food, or some substances prevent and make it insoluble or somehow bound to something, it can greatly decrease absorption, and vitamin D3 only can absorb present calcium. And as a result of all the three processes, bone resorption, greater reabsorption from kidney, and greater absorption from intestine, calcium is effectively restored back to norm, increased. Now let's observe the opposite situation, when calcium blood level becomes higher than normal. In this case, opposite reactions occur. Calcitonin is secreted in response to calcium elevation. But maybe number one effect is decrease of parathyroid hormone secretion and formation of vitamin D3. And so let's see which changes occur. Calcitonin suppresses osteoclasts, and so resorption does not occur and deposition starts to predominate, calcium deposition in bone. But anyway, number one effects for restoration of calcium back to normal are suppression of parathyroid hormone. So absence of parathyroid hormone produces decreased calcium reabsorption. Therefore, predominant process for calcium here becomes renal secretion due to parathyroid hormone mostly and absence of vitamin D3. And here decreased calcium absorption also occurs because there is no vitamin D3. Intestinal absorption is minimized and excretion increases. So due to all these changes, calcium deposition into bone, high renal excretion due to less reabsorption, and high intestinal excretion due to decreased absorption of calcium, calcium is finally decreased back to norm. So that's how we constantly regulate calcium level and prevent changes, abnormal changes of the central nervous system excitability. And that's all I wanted to tell about these types of hormone. And thank you for your attention.